Hi, this is Dr. Poole, and we're going to start off the first case of thrombocytopenia with primary hemostasis and related bleeding disorders. I'm going to start this off by just doing a brief review of normal hemostasis to put in context primary versus secondary hemostasis. And this is a team effort. This is a presentation as content that was developed by Dr. Ira Miller, one of our hematopathologists in the department, as well as Dr. Jerome Loew, who you've previously encountered in the GI course and also throughout the year. He's also a hematopathologist and recently retired from our department, but helping out. So here we go. For normal hemostasis, there's three fundamental elements that are required. First of all is that the blood vessel has to be integral. That means that the endothelial lining of the vessels has to be intact, and the blood vessel itself also needs to be intact. Secondly, you need functioning platelets, and you need platelets in sufficient numbers to form clots when needed. The third and final thing is there are multiple plasma proteins that are part of the so-called coagulation cascade. And these proteins are necessary to solidify the initial platelet clot. You also need to be able to dissolve the clot during the reparative phase, and this is where fibrinolytic pathways are important. The different clinical patterns of bleeding give some insight into what might be the underlying hemostatic problem with the patient. In platelet disorders, you primarily see mucous membrane and cutaneous bleeding, which manifests as petechia or purpura. This is sometimes collectively called mucocutaneous bleeding. Now, with clotting factor disorders, you get a different type of bleeding. That is deep hemorrhages or hemorrhage into joints. So these patients have hematomas that are situated deeply in the soft tissues or muscle, or they have frank bleeding into the joints. And so we'll talk about more of these clinical patterns of bleedings and the underlying mechanisms in the second case. And then finally, the vessels themselves can be fragile, and this is what you see with primary purpuric syndromes, which are not going to be discussed in detail really in the first couple cases, because we're going to try to keep a laser focus on hemostatic disorders. The normal physiologic response to blood vessel damage includes three essential steps. First is vasoconstriction. Secondly is primary hemostasis, that is formation of the initial platelet plug. And then finally secondary hemostasis, or the clotting cascade, in which multiple plasma proteins come together to generate fibrin, which holds the platelet plug together and in place. So let's look at this sequence of events in a little bit more detail. The first event is that arteriolar vasoconstriction occurs immediately and markedly reduces blood flow to the injured area. Now, this is primarily mediated by neurogenic mechanisms and augmented by the local secretion of factors such as endothelin. This is a potent endothelium-derived vasoconstrictor. The problem is that vasoconstriction is transient, and bleeding would not resume unless there's some activation of platelets and coagulation factors, so no clot is formed. The second step of primary hemostasis is where things really get interesting. And this is where you have the formation of the platelet plug. So disruption of the endothelium exposes subendothelial von Willebrand factor and collagen, both of which promote platelet adherence and activation. The activation of platelets results in a dramatic shape change from small rounded discs to flat plates with spiky protrusions that markedly increase the surface area and enable them to more effectively be joined together. There's also the release of secretory granules, and these include ADP and thromboxane A2, which are stored within the platelet and only released upon activation. In minutes of these products being secreted, additional platelets are recruited to the site of injury, and these undergo aggregation to form a primary hemostatic plug. This aggregation process is very dependent upon surface glycoproteins, which we'll talk about a little bit later. The next step is secondary hemostasis, and this is where you have deposition of fibrin. So tissue factor is another protein that's exposed at the site of injury. This is a membrane-bound procoagulant glycoprotein that's normally expressed by subendothelial cells in the vessel walls, such as smooth muscle cells and fibroblasts. It's normally hidden by the overlying epithelium, and so it doesn't promote coagulation. Tissue factor is important because it binds and activates factor VII, and this is a key step because it sets in motion a cascade of reactions that culminates in thrombin generation. Why is thrombin important? Because that's the enzyme that cleaves circulating fibrinogen into the insoluble fibrin and creates a fibrin meshwork at the site of injury. This meshwork is also a potent activator of platelets, leading to additional platelet aggregation at the site of injury. And this whole process is important because it consolidates the initial platelet plug and kind of glues it in place and glues it together. The final step is somewhat neglected usually and often not discussed with the importance that it deserves, because we don't just want clot formation to continue in an unregulated manner. It needs to be limited, and as you've probably guessed by now, all physiologic processes have an equal and opposite process to limit or curtail or even reverse the reaction, and this is no exception. So this is clot stabilization and resorption. So once the polymerized fibrin and platelet aggregates undergo contraction to form a solid permanent plug, this prevents further hemorrhage. At this stage, though, these counter-regulatory mechanisms, the release of tissue plasminogen activator, or TPA, and thrombomodulin, block further coagulation. And this also sets into motion additional steps that limit clotting just to the site of injury and eventually lead to clot resorption and tissue repair. Now, this process can also become unregulated, and that's when you get procoagulation or thrombotic events, which we'll talk about as well. So being well grounded now in the normal physiology of hemostasis, you can predict the etiology of different bleeding disorders. First of all, if you have abnormal blood vessels, that's an indication of vessel fragility and abnormal vessels, which are going to promote bleeding and or thrombosis. Obviously, you can have primary coagulation defects, and these include just the platelets being insufficient in number, which we call thrombocytopenia, or the platelets themselves can malfunction or be defective, and so the platelets don't aggregate together, or they don't release secretory granules to recruit additional sufficient platelets to form a platelet plug at a site of injury. You can also then have secondary defects of coagulation, and these are decreases in clotting factor activity. Now, as you've learned somewhat, the clotting cascade is a carefully orchestrated sequence of events, and so if any of these elements are missing or defective, it's going to impair the secondary hemostasis. And so this could be just due to insufficient production, which you learned about some in the food to fuel block. When there's liver disease, there's insufficient production of vitamin K dependent clotting factors. The clotting factors themselves can be abnormal because of some mutation, and we'll talk about this more in the context of hemophilia. Or the clotting factors can become depleted when there's some kind of massive stimulus to form blood clots in an unregulated manner. The clotting factor proteins can be consumed and lead to a depletion because they've all been involved in forming these abnormal clots. Let's turn our attention to laboratory evaluation of primary and secondary hemostasis. It's important to keep in mind that there's screening tests which just generally assess how intact a person's coagulation pathways are, versus specific tests which serve to identify the primary underlying abnormality. So screening tests include fairly simple things: the platelet count. Just want to enumerate the number of platelets. The second thing is the bleeding time. This is kind of a crude measure of how long it takes a person to form a blood clot and stop bleeding. It's a fairly simple test in a way, in that a measured nick is produced on a subject's skin, and then simply a timer is employed to see how long it takes for the injury to clot. It sounds, it's deceptively easy test, but of course it's subject to many false negative and false positive results. And so it's just a crude measure of bleeding. The prothrombin time, the activated partial thromboplastin time, and thrombin time are all in vitro assays to assess the coagulation cascade. Now, if one or more of the screening tests are abnormal, there's a variety of different specific tests that can be done to further determine what is the exact underlying disease or abnormality. The first level is to just look at the peripheral blood smear, and this is where you can confirm quantitative defects that are detected by automatic counting, as well as look for qualitative platelet abnormalities such as abnormal shapes or sizes of platelets. Platelets can also be detected in terms of their aggregation to different stimuli, and so these are sometimes useful when a primary hemostasis defect is suspected, or when patients are on different medications that might interfere with their function. Platelet release assays are also similar. Remember, we talked about there are substances that platelets secrete upon activation, and so we can test for those as well. There's a variety of different coagulation factor assays for each of the components of the coagulation factor pathway, as well as their inhibitors. And finally, we can assess the fibrinolytic pathways by looking at fibrin split products, and one of these fibrin split products is called the D-dimer, and this will be important when we talk about disseminated intravascular coagulation later. Okay, that was a long preamble to finally get to disorders of primary hemostasis. And these can be broken down into two things. One is you don't have enough platelets, which again we call thrombocytopenia, or the platelets can be defective, which we call platelet function defects. There are many different specific causes of thrombocytopenia, but in general we can lump them into a decreased production of platelets from some kind of a bone marrow abnormality, decreased platelet survival, which might be because they're coated with antibody and removed from the spleen, or they're injured due to some kind of drug interaction. The platelets can be sequestered, that is, the spleen, if it's enlarged, such as due to cirrhosis and portal hypertension, the platelets can be sort of soaked up by the spleen and not be available to the rest of the body in order to form adequate platelet plugs. And then finally, the platelets can be diluted, such as when there's massive infusion of red blood cells or fluids during massive or after massive hemorrhage. And so there may be a sufficient number of platelets, but in terms of their concentration, there's a relative thrombocytopenia. The first entity we'll talk about is immune thrombocytopenic purpura, or idiopathic thrombocytopenic purpura. In general, this is a clinical diagnosis. We'll talk about some of the clinical features, but basically, just like other primary hemostatic disorders, there's generally mucocutaneous bleeding, skin petechia, and easy bruising, or purpura. These are due to IgG autoantibodies that are formed against a variety of different platelet glycoproteins. And so these antibody-coated platelets are removed by splenic macrophages, which drives down the platelet count. So this is primarily a function of decreased platelet survival. The spleen is normally or normal in size, but it may have prominent germinal center activation, which reflects this humoral immune response. The bone marrow compensates by trying to increase production, so you'll see increased megakaryocytes in uncomplicated cases. Sometimes the response can be blunted, however, and so there's, in addition to a survival problem, there's also a production problem. Because the platelets are being kicked out of the marrow sooner, circulating platelets may be larger than normal, and this is reflected in the laboratory as a fraction of immature or reticulated platelets, and again, this is due to shortened platelet survival and increased transit in the marrow. ITP can be primary or secondary clinically. Primary just means that it's idiopathic or it's not associated with any underlying condition. It can also be secondary. That means that it is associated with an underlying condition. There's a variety of different viral infections, gram-negative bacteria, autoimmune or lymphoproliferative disorders, or drug-induced conditions that can be secondarily associated with ITP. In the case of viral infections, this is a case of mistaken identity. Antibodies against viral antigens cross-react with platelet antigens and coat the platelets, etc., and so on. With gram-negative bacterial infections, the bacterial lipopolysaccharides nonspecifically attach or glom onto platelet surfaces, which also increases their removal from the circulation. In lupus, lymphoproliferative disorders like lymphomas and chronic lymphocytic leukemia, it's a general disruption or perturbation of the immune system which triggers T-cell mediated suppression of platelet production. So a little bit different mechanism than antibodies being coated by something and then being removed. In drug-induced, the drugs themselves produce antibodies that bind to platelets, and so you have to have the drug in conjunction with the antibody. So the drug induces the platelet antibodies, and there's a variety of different drugs which I've listed below there that are associated with drug-induced ITP. ITP can also be subclassified clinically as acute or chronic. In acute ITP, these are usually children with an equal sex distribution. There's usually an abrupt onset because these are related to a preceding viral illness. These usually spontaneously resolve, although it may progress to a more chronic form in a proportion of patients. And this is treatable with steroids, and there's usually resolution and restoration of the platelet count. Chronic ITP is usually found in women from 20 to 50 years old, and this is the idiopathic form. That is, there's generally no underlying secondary form. This presents with mucocutaneous bleeding, usually frequent or long-lasting nosebleeds, or prolonged menstrual periods or menorrhagia, as well as skin petechia. The differential diagnosis is important to rule out secondary forms of ITP because this is same age group roughly that might be taking some of these medications associated with drug-induced ITP. This is also the primary sex and age group for autoimmune disease, as well as post-viral syndromes, and we want to rule out lymphoproliferative disorders like chronic lymphocytic leukemia and lymphoma. Another important cause of thrombocytopenia is heparin-induced thrombocytopenia, or HIT. This is an acquired platelet disorder and is a little bit different because it causes thrombosis in arteries and veins, this entity accelerates thrombosis, and so thrombocytopenia is actually due to consumption of platelets and decreased survival. This is fairly common, occurring in about 5% of patients who receive unfractionated heparin or low molecular weight heparin, although it's more common in patients receiving unfractionated heparin rather than low molecular weight heparins. So the mechanism is exposure to heparin stimulates IgG autoantibodies. Platelet factor 4 is on the surface of the platelet and binds to antibody-bound heparin, and this complex increases platelet activation, which leads to random thrombus formation and then consumption of platelets. It also accelerates removal of platelets that have the platelet factor 4 heparin antibody complexes in the spleen. So we have two things going on with HIT. First of all is increased consumption because of the formation of these random thrombi, and we have decreased survival because of increased uptake in the spleen. With HIT, we can see skin necrosis at the injection site. This may produce a sepsis-like picture with fever, chills, tachycardia, but hypertension instead of hypotension, which we might usually see with sepsis, and as well as dyspnea. The thrombi can cause limb ischemia as well as organ infarcts. We make the diagnosis with one of the specific coagulation tests for anti-platelet factor 4 antibody. HIT is divided clinically into two types, type 1 and type 2. In type 1, there's a mild reduction in platelets. It's usually transient and clinically not significant. It occurs relatively soon following the institution of therapy. This is not antibody mediated, so the anti-platelet factor 4 antibody test, if it's tested for at all, is going to be negative. It's a little unclear what the exact mechanism is, and it's really only detected if platelet counts are being done and the clinician astutely notices a dip in the platelet count. Usually the mean lowest platelet count is 100,000, and it usually returns to normal after a couple days, even with continuation of heparin therapy. Now, in contrast, the type 2 is the more clinically severe form of HIT. There's a number of different complications, which I'll detail on the next slide, but these can be life-threatening. This occurs a little bit later after heparin exposure, and this is the form that is antibody-mediated due to the heparin antibody complexes which are bound to platelet factor 4. These also have a lower mean platelet count, which just reflects the more widespread formation of thrombi affecting larger arteries and veins, and so increased consumption, and because the platelets are coated with these complexes, there's increased removal from the spleen. The complications of HIT include venous thromboembolism, occlusion of larger lower limb arteries, usually in the legs, but can be seen in the hands and fingers, so there's limb ischemia, which leads to gangrenous necrosis and may even require amputation. You can have areas of skin necrosis, not only at the injection site, but other areas as well. There's also infarcts in deep organs, primarily the kidney, heart, and brain. since these are the most oxygen needy organs. And an important complication is adrenal hemorrhage, which can lead to an acute adrenal insufficiency crisis. The last major cause of thrombocytopenias, at least not directly due to production, are so-called thrombotic microangiopathies. This includes a spectrum of clinical syndromes. We talked a little bit about hemolytic uremic syndrome in the past. With lab screening coagulation tests, the PT and PTT are usually normal, except for another entity that we'll talk about in another case, DIC. The mechanism is that obstruction of capillaries with platelet thrombi occur, and these partially obstructing thrombi cause red cell fragmentation as the red cells try to pass through these capillaries that are partially obstructed by small thrombi or microthrombi. The example of thrombotic microangiopathies is thrombotic thrombocytopenic purpura, or TTP. This is a thrombotic microangiopathy that's caused by deficient activity of Adams TS13 protease. This is an enzyme that cleaves von Willebrand factor, remember, which is exposed on the subendothelium from damage, into smaller multimers. And this is a regulatory enzyme that prevents pathologic accumulation of von Willebrand factor on endothelial surfaces and capillaries. So it is a counter-regulatory mechanism to actually prevent coagulation. So when it's deficient, excessive von Willebrand factor in endothelial surface increases the tendency for platelets to attach and accumulate, and endothelial damage results in platelet-rich thrombi in the microvasculature, which then leads to tissue ischemia, the microangiopathic hemolytic anemia, and then thrombocytopenia from consumption. Most cases of deficiency of this protein are due to the production of an IgG autoantibody, but there are inherited forms of TTP that are due to a mutation that results in a defective protein. There's various clinical risk factors for TTP. It tends to occur more often in women, those of African ancestry, as well as association with autoimmune diseases, particularly lupus. Other risk factors include sepsis, liver disease, pancreatitis, or recent cardiac surgery. All of these are associated with reduced levels or reduced ADAM TS13 activity. There's a classic high-yield information of the pentad of signs and symptoms that are associated with TTP, and this is a must-know factoid, I guess. These patients classically present with fever, thrombocytopenia, microangiopathic hemolytic anemia, transient neurologic defects, and renal failure. Intravascular hemolysis can be detected in the lab by hemoglobin in the plasma or urine. There's an increase in the indirect bilirubin, and haptoglobin, which functions to bind free hemoglobin, is absent. Patients present with mucocutaneous bleeding, lightheadedness, nausea and vomiting, abdominal pain, and easy bruising. Some of the laboratory features of microangiopathic hemolytic anemia include a decreased platelet count, the appearance of schistocytes or spherocytes in the peripheral blood smear. There's laboratory measures of hemolysis. The major enzyme in red blood cells is LDH, lactate dehydrogenase, and this is increased due to the release of this enzyme into the blood. As mentioned, the indirect bilirubin is elevated, and haptoglobin is reduced or not detected. You can use specific tests to assay for ADAM TS13 or look for the inhibitor of ADAM TS13 when you're looking for the autoantibody that binds to ADAM TS13. Now just to mention, because you have heard of at least two of these in other courses, there are other disorders that are associated with microangiopathic hemolysis. These include malignant hypertension. Again, you have abnormal small vessels primarily in the kidneys but throughout the body, which cause red cell fragmentation. Kind of related to this, which you learned about in the course before last, preeclampsia and HELP syndrome. And then finally, DIC, which again we'll talk about in an upcoming case. Now just to conclude this talk, there's more information on the osmosis high yield notes on platelet defects, but you can have bleeding with normal platelet numbers, and this is where there's some abnormality of the platelet itself. We'll talk about, again, coagulation factor problems, which are secondary hemostatic defects, but just briefly, platelet defects themselves. Most of these are acquired due to either a medication such as aspirin or other platelet binding drugs that are primarily given in the context of atherosclerotic heart disease. Aspirin impairs the ability of platelets to make thromboxane A, so that's one of the secretory products. Uremia causes a variety of deleterious effects on the platelet. And then what I wanted to finish up with primarily were these congenital disorders. These are rare inherited disorders, and as you can predict, there are defects of platelet adhesion. The most classic is Bernard-Soulier syndrome. This is where you have an abnormal von Willebrand factor receptor. You can have defective platelet aggregation. We see this in Glanzmann thrombasthenia, and this is due to a deficiency or defective platelet surface glycoprotein receptor, GP2B3A. And then finally, which I don't talk about in detail whatsoever, is disorders of platelet secretion. There's a variety of storage pool diseases in which platelets are not able to either package the storage products or release them in an appropriate manner. So again, there's much better and more detail on Bernard-Soulier syndrome and Glanzmann thrombasthenia in the references from osmosis cited in the study guide. But just to conclude, there's a nice illustration here of these defects. When you have Bernard-Soulier syndrome, you have a defective receptor which prevents effective binding to von Willebrand factor. With Glanzmann's thrombasthenia, there's a defect in this surface glycoprotein GP2B3A, and this prevents platelets from aggregating appropriately with other platelets and then undergoing the shape changes, etc., that are necessary for formation of the hemostatic blood. So sorry, this was a much longer presentation than usual, but I wanted to thoroughly cover everything. There's more in the reference study guide materials, and Pathoma has a nice summary as well.